Welcome back. So remember when I said there were 2 sketches in our series on bleeding? Well, that wasn't technically accurate. We've got one more sketch in this chapter, and it's on the opposite of bleeding. That's right, we're talking about hypercoagulable disorders. In this sketch, we'll cover some of the most common disorders that result in overactive blood clotting. Let's see if we can help these brave heroes escape the mental anguish that is thrombosis, shall we? Hypercoagulable disorders can be divided into 2 major groups: inherited thrombophilias and acquired hypercoagulable disorders. First, let's talk about inherited thrombophilias, which are disorders that predispose patients to venous thromboemboli, or VTEs. VTEs occur when blood forms a clot in a vein and partially or completely blocks venous return. Hence our recurring sketchy symbol, the bundle of sticks blocking up this blue river. Remember Virchow's triad from our DVT sketch in the cardiology unit? If not, head over and check it out. Virchow's triad identifies the interaction between 3 factors that promote thrombosis: stasis of blood flow, vascular endothelial injury, and a hypercoagulable state. In the inherited thrombophilias, an inherited baseline hypercoagulable state is the primary cause of blood clots, naturally. That said, it's important to note that even in patients with these conditions, DVTs can still be provoked by blood stasis or endothelial injury, the other 2 parts of Virchow's triad. Speaking of other sketches, remember our nifty, sketchy version of the coagulation cascade from our last sketch? Yeah, there's a whole bunch of steps. But when this cascade of coagulation factors kicks off, it eventually leads to clot formation. In our previous sketch on coagulation factor disorders, we talked about how deficiencies or abnormalities in these various clotting factors can result in excessive bleeding. In this sketch, we'll talk about how other abnormalities in this coagulation cascade can lead to excessive clotting. Let's start by talking about factor V Leiden, the most common inherited thrombophilia, represented by this bear trap with V-shaped spikes. Factor V is a procoagulant clotting factor. When activated as factor Va, it increases the production of thrombin, which results in clot formation. Thrombin is a clever guy, downregulating itself automatically to prevent excess clotting from occurring. It does this by converting protein C to activated protein C, which degrades factor Va, thereby stopping further clot formation. In factor V Leiden, a single point mutation affecting the cleavage site of factor V makes it so that factor Va can't be broken down by activated protein C. The result of that factor Va resistance to activated protein C? Unchecked thrombin activation and excessive clot formation. To help you remember this admittedly complicated process, check out this poor army corporal, our recurring sketchy symbol for protein C. He's all stuck in that broken factor V bear trap, unable to cleave it open to free himself. Ouch. After factor V Leiden, the second most common inherited thrombophilia is a mutation in the prothrombin gene G20210A, represented by this POW camp for this family of beavers. How cute and super sad at the same time. But hey, at least the little beaver babies are making the best of it. Speaking of which, these young beaver precursors are our recurring sketchy symbol for prothrombin. Because, prothrombin is the precursor form of thrombin. They're too young to be damming up rivers left and right, but give it time. Anywho, a mutation in the prothrombin G20210A gene leads to significantly increased prothrombin production, which means more thrombin production and more clot formation. Next up, 2 very similar inherited thrombophilias: protein C deficiency and protein S deficiency. As mentioned earlier, protein C, represented by our army corporal, is an anticoagulant and acts to break down factor V and factor VIII to decrease downstream thrombin production. Protein C uses protein S, represented by his sergeant, as a cofactor. So deficiency of either protein will lead to increased thrombin production and therefore increased clotting, which is why these 2 officers are stuck under that pile of sticks. Protein C and S deficiencies come in 2 distinct forms: a rare autosomal dominant inherited form and an acquired form secondary to an underlying medical condition. Acquired protein C and S deficiency can occur as a result of DIC, as it gets consumed away, or liver disease, since protein C and S are made in the liver. The last inherited thrombophilia you'll need to know is antithrombin 3 deficiency. Like protein C and S, antithrombin 3 serves as an anticoagulant, but it works by inhibiting both thrombin activity and factor Xa activity. Therefore, a deficiency of antithrombin 3 will lead to increased thrombin and factor Xa activity, fibrin formation, and, you guessed it, runaway clot formation. To help you remember that antithrombin 3 deficiency leads to runaway thrombin and factor Xa activity, just check out this defective antithrombbeaver cage, letting that factor X fox and thrombbeaver run loose. Notice how the cage door forms the numeral 3? With that bit of introduction out of the way, let's talk about the clinical presentation of these inherited thrombophilias. Since these 5 conditions all present similarly, we'll cover them all in one fell swoop. In general, the risk of VTEs increases with age. However, patients with inherited thrombophilias have an increased risk of VTEs at a young age. In fact, if your patient has an unprovoked VTE before age 45, you should suspect an inherited thrombophilia as a possible cause. The most common manifestation of hypercoagulable disorders are deep vein thromboses, or DVTs. That makes sense since DVTs are the most common type of VTEs. Remember from our DVT sketch that DVTs classically present with unilateral swelling, pain, warmth, and erythema of the affected extremity, represented by the red, swollen leg on this young soldier. Additionally, hypercoagulable disorders can also present with pulmonary embolism, represented by our recurring sketchy bird's nest in that lung-shaped tree. Classically, PEs will manifest as dyspnea, pleuritic chest pain, and rarely hemoptysis. Don't worry, that dude's not out of shape. Everyone gets short of breath when they climb the PE tree. For more details on the presentation and management of PEs, check out our sketch dedicated to it in the pulmonary unit. While DVTs are the most common form of VTE, clots can also form in other locations in the body, especially in patients with hypercoagulable disorders. One funky location where you might see blood clots in hypercoagulable disorders is in the abdomen, which is why we've drawn this brown mud stain on the soldier's midsection. Intra-abdominal VTEs include mesenteric vein thrombosis and portal vein thrombosis, represented by this broken liver-shaped lamp. Both conditions most commonly present with abdominal pain. Additionally, portal vein thrombosis can also lead to ascites and lower extremity edema if portal hypertension develops. Not to be outdone by the abdomen, we've also got to think about the brain. Cerebral venous thrombosis, represented by this mud stain on his helmet, is an uncommon manifestation of hypercoagulable disorders presenting with neurologic symptoms like headache, visual changes, or altered mental status. There's one more pretty unique symptom that certain patients can present with. And man, it is something you definitely can't unsee. Patients with protein C deficiency who are started on warfarin can develop a condition known as warfarin skin necrosis, which presents with purpuric, necrotic skin lesions on the trunk and extremities. They're pretty nasty looking, and they're represented here by the black mud patches on our Army corporal's uniform. Warfarin skin necrosis occurs due to occlusion of the subcutaneous blood vessels of the skin. But wait, isn't warfarin an anticoagulant? Follow along with me here. As you might remember from our coagulation factor disorder sketch, warfarin blocks activation of vitamin K, thereby decreasing the vitamin K-dependent synthesis of clotting factors 2, 7, 9, and 10. However, warfarin also decreases synthesis of the anticoagulant protein C and S. Protein C happens to have a very short half-life compared to the clotting factors that warfarin blocks. So once patients start taking the drug, protein C is the first factor to fall, creating a transient hypercoagulable state. For most people, this isn't clinically relevant, but in patients with protein C deficiency, in which levels of protein C are already low, this additional hit is enough to cause clinically significant clotting, manifesting as skin necrosis. Interestingly, this transient hypercoagulable state is the same reason why we use a heparin bridge in patients starting warfarin therapy until a therapeutic INR is reached. Similarly, these soldiers want you to know that war is hell, but they also want you to remember not to start warfarin on its own without a heparin bridge. Likewise, warfarin skin necrosis has also been described in the setting of protein S deficiency, but is somewhat less common than in patients with protein C deficiency. Either way, let these black mud splotches on the corporal and sergeant remind you not to give warfarin to patients with protein C or S deficiency. Alright, let's briefly cover a few pieces of history that should raise red flags for a possible hypercoagulable disorder. We mentioned earlier that a first episode of VTE at a young age should raise your suspicion for an inherited thrombophilia. Well, recurrent VTE should do the same. Make sure to ask about a prior history of blood clots, represented by these piles of sticks obstructing the river upstream from all the action in camp. Likewise, since many inherited thrombophilias are passed down in an autosomal dominant fashion, affected patients will often have a family history of VTEs and maybe even known hypercoagulable disorders. Let this family portrait, a recurring sketchy symbol for family history, falling out of the soldier's pocket, remind you to ask about blood clots and relatives, and to keep your photos closer to your chest in a war zone. When it comes to the physical exam, many of the signs you should look for will be driven by the patient's presenting complaints. For example, the classic signs of DVT, unilateral swelling, warmth, and erythema of the affected extremity, will commonly be present. Significant swelling may even result in a difference in diameter between the affected extremity and the non-affected one. So that's a fun thing to check for if you happen to have a tape measure in your pocket. Wait, you do? Wow, way to be prepared. Automatic honors for you. Also, why? If your patient's got a PE, look out for tachypnea, dyspnea, and tachycardia. Represented by our recurring sketchy symbol, the heart-shaped stopwatch spinning out of control. An abdominal exam may reveal diffuse tenderness in patients with mesenteric vein thrombosis or lower extremity edema and ascites in the setting of portal vein thrombosis. Lastly, a neuro exam may show signs such as altered mental status, vision changes, or papilledema in patients presenting with cerebral vein thrombosis. Diagnostic testing, for the most part, should be performed only when the results of the test will affect prognosis or management. Given the lack of consensus on when you should test patients presenting with VTEs for an inherited thrombophilia, it can get pretty confusing for literally everyone. That's why it's important to keep the big picture in mind. The reason we look for hypercoagulable disorders in patients presenting with blood clots in the first place is to better characterize their risk for future clots and to come up with a plan to prevent that from happening while balancing the adverse effects of too much treatment. We're going to do our best to boil down all these recommendations for you, but remember, this stuff is even difficult for attendings to get straight. Note that these recommendations we'll present are synthesized from multiple professional societies and thus form one of many reasonable ways you can navigate diagnostic testing. Generally speaking, patients presenting with their first DVT don't benefit from testing for hypercoagulable conditions unless they have certain risk factors for inherited thrombophilias, including a strong family history of VTEs, such as a DVT in a first-degree family member who's younger than 45, a patient younger than 45 who presents with an unprovoked VTE, patients with recurrent VTEs, and patients presenting with VTEs in uncommon places, like the portal, mesenteric, or cerebral veins. Sometimes, though, the decision to test is pretty easy. Remember these soldiers with black mud splotches all over? If your patient presents with skin necrosis and is taking warfarin, you've got to test for protein C and S deficiencies. In addition to inherited thrombophilias, patients with recurrent VTEs or VTEs in uncommon locations should also be tested for antiphospholipid antibody syndrome, an acquired hypercoagulable disorder that we'll cover a bit later in this sketch. Okay, so we've drilled when you should test into your head. Now you've got a patient with some of these risk factors and you're concerned for an inherited thrombophilia. How do you test? Well, most labs can perform a thrombophilia panel that tests for all 5 of the major inherited thrombophilias we've discussed. Factor V Leiden, prothrombin G20210A gene mutation, protein C and S deficiencies, and antithrombin 3 deficiency. That's why we've drawn in this colorful control panel complete with 5 different levers. Some of the specific tests performed include genotyping for mutations, while others are assays that measure direct protein levels or activity. Either way, an abnormal result will clue you into the specific inherited thrombophilia that's at work. One last note about the when of testing. There are a couple of times when diagnostic tests won't be accurate: acute thrombosis and anticoagulant use. Both of these conditions will artificially alter levels of anticoagulant factors commonly tested in thrombophilia panels. Therefore, if your patient has active thrombosis or is taking anticoagulants, testing should be delayed so that you won't get a false positive result. Clearly, when a patient presents to you with an abnormal blood clot, inherited thrombophilias shouldn't be the only thing you think of. Instead, your differential diagnosis should include a number of other acquired hypercoagulable disorders. If you diagnose a VTE and suspect a hypercoagulable disorder, the first set of conditions you should rule out are the acquired hypercoagulable disorders, since they are much more common. Risk factors such as malignancy, recent surgery, recent hospitalization or immobility, recent long-distance travel, pregnancy, nephrotic syndrome, collagen vascular diseases like lupus, and medications like OCPs should all make you think of an acquired hypercoagulable disorder first. Other acquired hypercoagulable conditions to consider include myeloproliferative diseases like polycythemia vera, advanced liver disease, and antiphospholipid syndrome. But we'll talk about that last one a little later in this sketch. One more thing. If your patient has recently received heparin, heparin-induced thrombocytopenia should also be up there on your differential. By now, you can probably see why a thorough social and medical history are super important when building a differential for your patient presenting with a VTE. If you come up empty after this exhaustive search for answers, an inherited thrombophilia just might be the answer. Now that we've gone over some of the different types of inherited hypercoagulable disorders, let's check out a sample assessment. Major Clipton is a 30-year-old male who presents with right leg pain and swelling for the past 3 days. His medical history is unremarkable. He does not take any medications and is physically active. Physical exam is significant only for an erythematous, edematous, tender right calf. Doppler ultrasound confirms a right popliteal DVT. Given his relatively young age for a first unprovoked DVT, I'm concerned for an inherited hypercoagulable disorder such as factor V Leiden. Let's say you've tested your patient for an inherited thrombophilia and, what do you know? They have one. What are you supposed to do now? Fortunately for your brain, patients with inherited thrombophilias presenting with a DVT should be treated with anticoagulation just like patients without inherited thrombophilias. At Sketchy, anticoagulation therapy is represented by a recurring bottle of anti-clog solution. For their first DVT, patients with inherited thrombophilias should be anticoagulated for at least 3 months. Hence the 3 moon-shaped searchlights flooding the field. 3 months is really the standard length of time for anticoagulation therapy. However, there are certain scenarios where most clinicians agree that patients should remain on anticoagulation for longer than 3 months. Multiple inherited thrombophilia, a strong family history of VTEs, recurrent VTEs, VTE at an atypical site, or a life-threatening VTE such as a PE. Don't worry about getting the exact length of time correct. The appropriate duration of treatment, up to and including indefinite anticoagulation, can vary based on a lot of factors, and from one provider to the next. It's much more important to know that 3 months is the minimum. For more information on anticoagulation, be sure to check out our DVT sketch in the cardiology unit. For patients diagnosed with an inherited thrombophilia who have no history of VTEs, anticoagulation is usually not required. That said, high-risk patients, that is, patients with antithrombin deficiency, more than one inherited thrombophilia, or a very strong family history of VTEs, should receive prophylactic anticoagulation in the settings that increase the risk of blood clots, like post-op, during pregnancy, and postpartum. Hence our recurring sketchy symbol for prophylaxis, the PPX shield held by our pedigree map-wielding soldier. As you might expect, part of the management of patients with inherited thrombophilias includes avoiding risk factors for blood clots, including use of OCPs, represented by this OCP-shaped manhole cover, or other high-risk medications such as estrogen replacement therapy, tamoxifen, testosterone, bevacizumab, and systemic glucocorticoids. And, of course, avoid trespassing in sewers and POW camps. No wonder this guy looks so nervous. There's one specific therapy to mention before we move on. In patients with protein C deficiency, warfarin should be avoided due to an increased risk of warfarin skin necrosis. Makes sense, right? That's all for the inherited thrombophilias. Let's now move to the other side of the river to talk about acquired hypercoagulable disorders. Most acquired hypercoagulable disorders aren't technically diseases. They're more like acquired hypercoagulable states. Remember that DVT sketch from the cards unit? I know we keep going back to it, but we go over so many of the acquired hypercoagulable states in that sketch. These states include malignancy, post-op status, prolonged immobilization, pregnancy, nephrotic syndrome, collagen vascular disease, and hormone replacement therapy, among others. Since we've discussed those acquired hypercoagulable states at length in our DVT sketch, seriously, go check it out if you haven't yet. we'll focus on the one that we haven't talked about yet, antiphospholipid syndrome. Antiphospholipid syndrome is an autoimmune hypercoagulable disorder characterized by the presence of, antiphospholipid antibodies, represented by these antibody-shaped poles up on this wall. These autoantibodies promote thrombosis through their procoagulant interaction with protein C, tissue factor, and platelets. Although the pathophysiology is not completely understood, the current hypothesis is a variation of the two-hit theory. An individual who acquires a first hit, such as lupus, who is then exposed to a second, like pregnancy or malignancy, then develop the namesake autoantibodies that lead to clotting. Notably, antiphospholipid syndrome is also well known for causing preterm births and spontaneous abortions. Unlike the other hypercoagulable disorders we've covered today, antiphospholipid syndrome is unique in that it causes both venous and arterial blood clots. Hence these sticks piled up on this stream of red sap. You should suspect antiphospholipid syndrome in young female patients presenting with recurrent thrombotic events that can't be explained by other causes. Specifically, if your patient has a history of unexplained miscarriages, antiphospholipid syndrome should be pretty high up on your list, which is why this young female soldier sitting up in the tree has a pregnant belly. Even though antiphospholipid syndrome can cause arterial thrombi, venous blood clots are still more common. The venous thrombi caused by antiphospholipid syndrome are just like the ones caused by any other hypercoagulable disorder. Once again, this means unilateral swelling, pain, warmth, and erythema of the affected extremity, which is usually a leg. And just like the other hypercoagulable disorders, where there are DVTs, there can be PEs. Remember the classic symptoms of dyspnea, pleuritic chest pain, and rarely hemoptysis. Likewise, antiphospholipid syndrome can also cause VTEs in unusual locations, such as intra-abdominal venous clots, which can present with abdominal pain, and cerebral venous thrombosis, which can present with neurologic symptoms. Proximal or upper extremity VTEs, such as axillary, subclavian, or inferior vena cava clots, should be red flags for antiphospholipid syndrome as well. Remember though, antiphospholipid syndrome isn't limited to just the venous system like the other thrombophilias. Nope, APS can cause arterial thrombosis as well. Arterial clots most commonly occur in the cerebral arteries, leading to ischemic stroke and transient ischemic attacks. Hence the brown mud splotch on this red guard's helmet. Red for arteries, of course. Anywho, watch out for neurologic symptoms like unilateral weakness, slurred speech, confusion, and ataxia, especially in a young patient without any other risk factors for stroke. Arterial thrombosis can also manifest in the form of retinal artery occlusion, represented by the mud splotches on this red guard's binoculars, and organ ischemia from things like pulmonary, renal, or mesenteric artery thrombosis, represented by the mud splotches on his chest and abdomen, and limb ischemia and osteonecrosis from arterial thrombosis in the end arteries of the extremities and bone, represented by the mud splotches on his leg. Once again, a history of recurrent thrombosis, especially in a patient without risk factors, should raise red flags for a hypercoagulable disorder like antiphospholipid syndrome. We mentioned this earlier, but there's one piece of history that should really raise your red flags for antiphospholipid syndrome, and that's a history of unexplained pregnancy complications. These include recurrent unexplained spontaneous abortions, fetal loss after 10 weeks, and premature birth. APS is thought to cause these complications due to placental artery thrombosis, leading to decreased blood delivery to the fetus. Hence the knocked-over baby carriage by the banks of the river. While antiphospholipid syndrome can occur as a primary disorder, it's frequently seen in patients with other autoimmune diseases, especially lupus. That's why we've drawn in our recurring sketchy symbol for SLE, the lupus wolf, barking up that arterial thrombus tree. No, bad wolf! Let's take a look at some of the objective findings you might see in a patient with antiphospholipid syndrome. Remember that DVTs, the most common manifestation of APS, classically present as unilateral swelling, increased calf diameter, warmth and erythema of the affected extremity, while PE will produce signs like tachycardia, tachypnea, and hypoxemia. Remember to perform a thorough neuroexam looking for signs of cerebral arterial thrombosis, which can present with signs like hemiparesis, dysarthria, altered mental status, and ataxia. Interestingly, antiphospholipid syndrome can actually affect the heart valves, producing non-bacterial vegetations known as Liebman-Sachs endocarditis, which is represented here at Sketchy by that sack lunch. complete with a heart on the sac. Liebman-Sachs endocarditis most commonly affects the mitral and aortic valves, so listen for murmurs of mitral or aortic regurgitation on exam. To help you remember the findings of Liebman-Sachs endocarditis, just check out this sloppy night watchman, slacking on the job as he regurgitates beer and plays his radio on blast. One last classic exam finding you might see in antiphospholipid syndrome is a skin condition called livedo reticularis, which is caused by dermal thrombosis. It looks like a patchy, reticulated, net-like pattern of purplish discoloration on the skin, kind of like the pattern on our Red Guard's pants. If you've studied up on antiphospholipid syndrome before, you might have heard about these unique lab findings. First, APS frequently causes a mild to moderate thrombocytopenia, although it's usually not significant enough to cause bleeding issues. We are talking about a hypercoagulable disorder, after all. In addition, the APTT may also be elevated. Wait, aren't we talking about hypercoagulable disorders? Why is the APTT prolonged? This paradoxical effect is caused by the lupus anticoagulant autoantibody. These autoantibodies bind and disrupt function of phospholipids, some of which are used to measure the activated partial thromboplastin time. The end result is a prolonged APTT that won't correct even when mixing with normal plasma. But don't worry, it's just a lab artifact. The patient is definitely still hypercoagulable. As if one false positive test weren't enough, patients with APS can also have false positive VRDL and RPR tests. Fortunately, this does not mean that your patient has syphilis. Well, probably doesn't have syphilis. Just like the APTT, it's a lab artifact triggered by the presence of antiphospholipid autoantibodies. The VDRL and RPR tests utilize the phospholipid cardiolipin. Since many patients with antiphospholipid syndrome have anticardiolipin antibodies, they can test falsely positive for syphilis if you inadvertently use these tests. Antiphospholipid syndrome can be pretty tough to diagnose, which is why we have diagnostic criteria to help us out. The diagnosis of antiphospholipid syndrome is made based on the combination of clinical and laboratory criteria. Clinical criteria include thrombotic events or pregnancy complications, while lab criteria include the presence of one of the specific antiphospholipid autoantibodies, which we'll discuss in a moment. Patients must have at least one of each to be diagnosed with APS. Speaking of which, let's go over the specific antibodies you'll need to test for to make the diagnosis of antiphospholipid syndrome. The three autoantibodies to test for include anti-beta-2 glycoprotein 1, represented by the two betas in this sign, anticardiolipin antibodies, by the heart-shaped tear in the soldier's uniform, and lupus anticoagulant, represented by our recurring sketchy lupus wolf. The presence of any of these three antibodies on 2 or more occasions at least 12 weeks apart meets the lab criteria portion of the diagnosis of APS. As you might expect, the differential diagnosis for antiphospholipid syndrome includes, well, everything we've talked about in this sketch. Namely, we're talking about acquired hypercoagulable states such as malignancy, post-op status, prolonged immobilization, pregnancy, nephrotic syndrome, and hormone replacement therapy. In addition, since many patients with antiphospholipid syndrome will present with VTEs at a young age, make sure to think about the inherited hypercoagulable disorders we've discussed in this sketch as well. Let's summarize the clinical presentation of antiphospholipid syndrome with a sample assessment statement. Ann Sears is a 28-year-old female presenting with leg pain and swelling for the past 2 days. She does not take any medications, has no surgical history, and has not had any recent travel. Her medical history is significant for 2 first-trimester miscarriages. Physical exam is significant for erythema and tenderness of the right lower extremity. Labs are significant for a platelet count of 90,000 and a prolonged APTT. Ms. Sears' presentation is consistent with the DVT, and given her history and lab findings, I'm concerned for antiphospholipid syndrome as the underlying cause. Due to the high risk of recurrent thrombosis, patients with antiphospholipid syndrome require long-term anticoagulation, represented by the bottle of anti-clog solution in our female soldier's hands. Yikes, look at the time. Guess she's been hiding in that tree for a while. And just like any other hypercoagulable disorder, patients with antiphospholipid syndrome should be advised to avoid factors that might increase the risk for clots, including the use of OCPs. Okay, soldiers, let's wrap up with a brief review of what we've learned. We started on the right side of the river, going over the inherited hypercoagulable diseases, including factor V Leiden, in which protein C can't cleave factor V, prothrombin gene mutation, where there's increased prothrombin, protein C and S deficiencies, leading to increased factor V and VIII, and antithrombin deficiency, which leads to elevated factor X and thrombin. Inherited thrombophilias commonly present as DVTs, which can develop into PEs. Red flags for inherited diseases, like unprovoked VTE in young patients less than 45, VTE in sites other than limbs, like the portal, mesenteric, or cerebral veins, recurrent VTEs, and a family history of VTEs should make you consider testing these patients with a panel of tests for the inherited thrombophilias we discussed, as well as antiphospholipid antibody syndrome. In general, a first-time DVT should be treated with anticoagulation for 3 months, even if they have an underlying inherited disease. Duration of therapy really depends on overall risk factors for recurrence. If patients are diagnosed but don't have a history of VTE, they don't necessarily need anticoagulation, but they do need prophylactic anticoagulation postoperatively, during pregnancy and postpartum, and should definitely avoid things that increase their risk of VTE, such as certain medications like OCPs. We next moved on to discuss acquired hypercoagulable states. Most of these are risk factors we went over in the DVT sketch, such as malignancy. On the left side of the river, we discussed antiphospholipid syndrome, which can cause venous and arterial thrombosis, as well as pregnancy complications. Arterial thrombosis and APS can manifest as ischemic stroke, TIA, retinal artery occlusion, and blood clots in virtually any artery of the body. Antiphospholipid syndrome is frequently associated with SLE. Once again, DVTs are common and can precede PEs. Other random findings that can be suggestive of APS include livedo reticularis and Libman-Sachs endocarditis. Diagnosis of APS requires a combination of clinical and laboratory criteria, including the presence of antiphospholipid antibodies such as lupus anticoagulant, anti-beta-2 glycoprotein 1, or anti-cardiolipin antibodies. Management of APS typically requires long-term anticoagulation and avoiding other risk factors for blood clots. And that's it for hypercoagulable disorders. Good on you for making it to the end without yelling, "Madness! Madness!" No, I don't know, I'm not there. Maybe you did. Anyway, see you next time.